Our second session today is called Sharing the Big Ideas, Why Knowledge is Power. Our first speaker, Kristina Talbert-Slagle. Kristina Talbert-Slagle grew up in Kentucky and is a proud alum of the Vampy summer program at the Center of Gifted Studies at WKU. She was a single-terry scholar at the University of Kentucky, graduating in 2001 with degrees in Russian and Eastern Studies and Agricultural Biotechnology. She completed her PhD at Yale in 2010 and has since been working in global health, where she unites her interests in interdisciplinary sciences, complex systems theory, and strengthening health systems. She is now an assistant professor at the Yale School of Medicine. Please welcome Kristina, everyone.
Thanks. Thanks. Hi, everybody. It's great to be here. I'm glad to be back in Kentucky. I'm originally actually from Henderson, which is not very far away. I don't know if anybody here is from there. But as I said, thank you for the introduction. I'm here to talk to you about global health. And there's a big idea coming at the end, but first, let's kind of ask, what is global health? So Patrick, if you could just do my slides. Okay, so let's start by thinking about what's shown here in this picture. So this is someone who has come to a healthcare facility seeking care. This person doesn't feel well. And here's a healthcare provider. Could be a doctor, could be a nurse, could be a community health worker. So what are some factors that are going to affect whether this person who's not feeling well gets better? You could imagine, let's think about what happens before these two people even came together. So in some parts of the world, this patient had to walk for miles and miles to get to this healthcare facility. Sometimes they have to pay. Sometimes they don't have the money. If you don't have transportation, don't have a vehicle to get to a healthcare facility, then you're going to come less often. So this interaction between patient and healthcare provider, this might be a rare event. This person could be really sick already because they haven't had a chance to get to a healthcare facility often enough not to get really sick before they get care. But here they are, they're together. What might affect the ability of the healthcare provider to help this person get better? So imagine, for example, they speak two different languages, or maybe they're from two different cultures. Maybe they are two different races, two different genders. If the patient is a woman, in some parts of the world, she has to ask her husband's permission to get health care. The healthcare provider may not have quite the training that he or she needs to understand what's wrong with this patient and how to help. Or what if there's something so simple as needing a pair of gloves, or needing a sterile syringe, or even needing a bandage? In some places, having the supplies that are needed is not a given. Or if they need a machine to do a diagnostic test, maybe the machine's not there, maybe there's no power to run the machine. Maybe the healthcare worker hasn't been paid in a while. Sometimes that happens. And then you can imagine all the things that can happen around this interaction afterwards. So let's say the healthcare provider provides a diagnosis and says, you need this and this and this medicine. What if the patient can't afford the medicine? What if the medicine's not available? Some places, including in the United States, if this patient is homeless, they may get the diagnosis they need, they may know what medicines they need to take, but if they don't know where they're sleeping that night or where their next meal is going to come from, they may not be able to take their medicine, they may not be able to get better. So when we think about global health, we're thinking about all those things that affect when a person who is sick comes to health care. Can they get there, get the quality of care that they need? Can they have access to the medicines? Is a healthcare worker supported? And let's think about this in a real-world example. So we'll talk about the country of Liberia, which is shown here in red on the slide. It's in the continent of Africa. It's one of 54 African countries, and it's in an area called West Africa. So here's a close-up. You can see Liberia is bordered by Sierra Leone, Guinea, and Cote d'Ivoire. Liberia is about the size of the state of Tennessee, geographically, has about 4.5 million people. And it has an interesting and deep history with the United States. It's called Liberia because in the mid-1800s, freed former slaves from the United States were taken to this part of Africa to start a new colony, a new life. And so they named this area Liberia for freedom. And the capital of the country is called Monrovia, named after James Monroe. And you can see the connection because this is a Liberian flag. Looks a whole lot like the US flag. But there were people already living in this area of Africa and had been living there for hundreds of years. So when the repatriated slaves from the United States were brought here, it introduced tension between the people who were already living there, the indigenous people, and the Americo-Liberians. And in 1989, that erupted into a war. This is a famous picture of a little boy who's wearing a teddy bear backpack, and you can see he has a gun, and he's pointing it right at the photographer. The Liberian Civil War, there were two of them actually, they lasted over a period of 14 years, and they were incredibly violent. And they were known for child soldiers. And they absolutely destroyed the country. More than 90% of the people who provided healthcare in Liberia left. Healthcare facilities were destroyed, and they were closed. And other systems, I mean, you can see buildings were destroyed, the power systems were destroyed, schools were closed, and lots of people left. People who could get out, educated people, people who were professionals. So what did that mean for the healthcare system? Well, in global health, one of the ways that we kind of assess how a health system is doing is by looking at what's called child mortality. So this graph is showing you the mortality rate in children under the age of 5. And the blue line is Liberia, the red line is its neighbor Guinea, and the green line is its other neighbor Sierra Leone. And then the dashed black line is an average of countries in this region. So you can see in 1980, for about every 1,000 babies born in Liberia, the blue line, about 250 of them did not make it to the age of 5. This was a place where, at this time, the healthcare system wasn't able to meet the needs of the people. And you remember the Civil War was from about 1989 to 2003, and you can see a bump in the blue line. Child mortality went up because the healthcare system wasn't working. But the good news is that the lines are all going down. So child mortality is declining. The health system is getting better. And so this line stops right now at 2003, roughly, after the Civil War. But then as we continue, look, all these countries were getting better. Child mortality was going down. The health systems were improving. But they were still very fragile. So here's some data from 2012, and this is another way we can measure how health systems are doing. This is the number of doctors in a country for every 100,000 people living in that country. So you can see in Spain, there are hundreds of doctors for every 100,000 people. Also in the United States. Guinea at this time had 10. Liberia at this time had just over, on average, 1 doctor for every 100,000 people. So this was still a fragile health system, recovering from war, but fragile. And if you think about it, a health system's job is not just to help people who are sick, like I talked about at the beginning, but also people who need routine care, women who are pregnant, providing vaccinations for children, your wellness checkup that you're supposed to have every year when you go to the doctor. So when you don't have enough doctors and you have a fragile post-war system, it's tough. But Liberia was getting better. Then, in March of 2014, Ebola emerged. Ebola is a virus. It's classified as an emerging infectious disease. The first reported cases were in 1976 in a different part of Africa. When it emerges, it is a very serious illness. It can be deadly. Here, I don't know if you can read it, but 59% of the people who had Ebola at this time in March had died. And it emerged in this fragile place where the health systems were fragile. So let's see what happened. So here these maps show the area of West Africa that I showed you before. You can see Liberia and its neighbors Guinea and Sierra Leone. So Ebola started in Guinea, in a town called Gwekadu, I think is how you say it. And then the shading shows you how many people had died. So this is what happened over time. So we start in March, go through the end of 2014, look how this is spreading. And people are dying, and this stops at March 2015. The outbreak actually did not stop at this time, but the maps stop here. And you can see every place that's dark had more than 500 deaths. Thousands of people were infected with Ebola, and thousands died. In Liberia alone, more than 4,800 people died of Ebola. But let me just take a step back here and tell you something about infectious disease spread in general, because not all infectious diseases spread the same way. And Ebola is not as transmissible as many other viral and bacterial diseases that can make people sick. So there's an interesting question there. How is it that a virus that's not that transmissible caused infections of thousands of people and caused thousands of deaths? So what are we looking at here? So on your left, there's the dark blue figure. This is a person who's sick with an infectious disease. And as you all know, when somebody's sick, they cough, they may sneeze, whatever, vomit. I know it's gross, but it happens. Bodily fluids. So some infectious diseases in those bodily fluids are released, and they really can only spread very close by the sick person. That's called droplet transmission. And you can see here the big red circles are the droplets. Other infectious diseases release much tinier particles that can actually travel through the air, travel very far, and infect people far away from the person who's sick. That's shown here on the far right in the light blue. Teeny tiny pieces of infectious particles can travel very far. That's airborne. Ebola was not airborne. Never has been. It wasn't in West Africa, and it wasn't in any of the earlier outbreaks. So this shaded area around the dark blue person, that's about how far Ebola could travel, which means it really infected only the people who were very close to the sick person, the caregivers, the families, the loved ones. And why did that happen thousands and thousands and thousands of times? It's because they weren't able to rely on their health system to isolate the person who was sick. Healthcare workers did not have basic supplies like gloves, face masks, suits to protect themselves when they were providing care to people who had Ebola. So those thousands of deaths were really a product of a healthcare system that just absolutely couldn't handle. It was too fragile to handle an emerging infectious disease. And it's because of the war. They had only had 11 years to try to recover from that long, violent war period. And during the time of Ebola, as I said, thousands of people died of Ebola, but people also died, women died in childbirth. Healthcare facilities were closed. 62% of healthcare facilities in Liberia outright closed. Can you imagine that? You couldn't even get to a healthcare facility. But I started out talking about global health, and this is about big ideas. So what's happening now? During the day, during the Ebola outbreak, the people who were in leadership in Liberia were trying to deal with the crisis. But at night, they were writing this: the investment plan for building a resilient health system in Liberia. And the introduction is written by the president of the country, and she says, never again are we having this, never again. So they wrote a whole huge plan for how to rebuild their health system so that it would be resilient. And what do they mean by resilient? They mean that it can handle a crisis like Ebola, and it can also handle the everyday, ordinary things that need to happen in a healthcare system. When a woman is in labor, the healthcare system can take care of her. Never again, their goal is never again to have children not get vaccinated like they need to be. The leadership in Liberia on this has been absolutely amazing. Look at it, it says, in response to the Ebola virus disease outbreak of 2014-15. I mean, they were writing this at night while they were dealing with Ebola during the day. I know I said that, but talk about a big idea. So what's happened since then, let me see if this will work, is that people all over the world, including our team at Yale, has said, let us help you. We want to get involved. We're excited about your vision. We want to come and we want to work with you and we want to help you build this resilient health system. And they said, great, come on board. So what are we doing? This is the major teaching hospital in Monrovia, the capital city of Liberia. Note that it's called JFK. It's named for John F. Kennedy, and he was there at the dedication. So there's this deep, long tie between the US and Liberia. And there are people brought from all over to help train doctors there, to help work with people who are managing the facility, to help it run more efficiently. There's another hospital called Redemption. This is a free public hospital. Also, our teams have people there helping to make things run a little bit better. They're doing things like tracking the inventory in the pharmacy. What medicines do we have? What gloves do we have? What supplies? What's needed? What's expired? And then there are also people doing medical teaching. So this is at the medical school in Monrovia, and it's a neuroscience class. And there are people who have come to help teach doctors so that when they're in that healthcare facility, they're better trained. So it turns out, hopefully from this, the takeaway is that it takes a lot more than just coming to a facility, having a good doctor, and getting the medicine that you need. It's about access to care, being able to get there, the quality of the care, supplies, support from all around, making sure the facility is well run. So I'll leave you with two big ideas in global health, exemplified by two quotes. The first one is, these are both from Dr. Tedros Adhanom Ghebreyesus, who is the new Director General of the WHO. The first big idea, everyone should have access to the health services they need, when and where they need them, without suffering financial hardship. And the second big idea is no one should get sick and die just because they are poor or because they cannot access the health services they need. That's what I think global health is, and that's our big idea. Thanks.